I hope you all are fine. And today we are going to have a discussion on your thyroid gland. So basically, what we are going to do is many of the lectures I see that some teach you anatomy, some teach you biochemistry, some teach you physiology of thyroid gland. Okay, anatomy means the basic understanding of thyroid gland, arteries supplying the dimensions. Okay, the relations, all of them. Okay, and basic ones, not of so high level or not covering all the relations, but which are important for an exam point of view, be it PUSMLE or your NEET PG or your props as well. And some teach the physiology of thyroid gland, that is the iodine trapping, how the hormones are secreted out, what is the effects of hypothyroidism, hyperthyroidism, okay, what are the manifestations, what are the effects of thyroid hormones on different organs. Okay, we are gonna cover them all also, as well as we are going to look at the biochemical aspect. Biochemical aspect means the thyroid function tests. Okay, so today we are going to look at the anatomy of thyroid gland, then the physiology of thyroid gland, all the functioning and hormones, as well as the biochemistry of thyroid gland. Uh, in addition to this, the your preclinical, we're gonna see some thyroid tumors as well, and the carcinomas and all the pathology as well. Okay, so of thyroid, we're gonna do all of them which are needed for a great understanding of the clinical aspects. Clinical aspects is altogether a different domain, but first we have to know the basics. So these are your basics. That is, we have to build the thyroid gland from scratch. We will see how the thyroid gland is made, what is its function, how do you test the functioning of thyroid, then what are the abnormalities. Then afterwards, you watch any lecture, any medicine, you pick up any book, Harrison, Davidson, anyone. Okay, then you will find it very easy to understand all the terminologies, all the functioning, what is happening, which drug you have to give, all of them. Okay, we're not going into pharmacological aspect, as it is we'll read in medicine the different what are the diagnosis and what is the treatment and all. We're not going into that. We're gonna discuss the pathology. Okay, up to pathology we'll limit our discussion. Let's start. Some things I'll be writing, and as we have to cover a lot, so I can't write. So I will show you the things which I won't write in my handwritten notes. Okay, let's start. Let's start with the basic anatomy of thyroid gland. Okay, so thyroid gland, is an endocrine gland. It has you must have seen the gland. It has two lobes. Okay, just pardon my drawing. First lobe, second lobe, and an isthmus in between. Okay. This is the basic structure of the thyroid gland. What is its extent? Extent is from C5 level to T1 level. Okay, basic extent is C5 to T1, although it may vary according to the size. Okay, and thyroid gland is connected to your hyoid bone. Okay, with a levator glandule thyroidae. Okay, this is the name of a fibrous strip of tissue, which is also called as a levator glandule thyroidae. Okay, this is the connection. And isthmus is present in front of your second to fourth tracheal cartilage. Okay, let's say this is a cartilage, so isthmus must be present in front of this, like this. So second to fourth tracheal cartilage, it's present in front of this. Okay, understood. For dimensions is very easy. Remember, 5 cm. This is the dimension of the gland, and there is a dimension of your isthmus as well. Gland dimension is 5 cm into 2.5 cm into 2.5 cm. Okay, and the dimension of the isthmus. Okay, isthmus is just you can imagine it like a rectangle. Okay, just length and breadth and all. Okay, so it is 1.2 cm into 1.2 cm, although books vary in this statement also. Okay, and this thyroid gland is covered by capsule. So capsule of thyroid gland is divided into two types, that is a true capsule and a false capsule. True capsule is present in the capsule part, and a false capsule is present. Understood? This true capsule, false capsule, what is the basic theory is that the true capsule is always any of the glands. Okay, true capsule is always the condensation of the gland's own stroma. Okay, the condensation of the gland's own stroma is called as a true capsule, and false capsule is the modification in case of thyroid gland, is the modification of suspensory ligament of Berry. Modification of suspensory ligament of Berry. You know the suspensory ligament of Berry? Okay, the pretracheal layer and the uh, if you don't know, let me just draw a diagram for you. Just see this. This is a thyroid gland. Okay, and let's draw the cartilages as well. We are seeing from the side view. Okay, we are seeing the neck from the side view. Let me draw this cartilage. This is a cricoid cartilage, and this is a thyroid cartilage. So these are the cartilages, and there is a ligament which is connecting the thyroid gland to the cricoid cartilage. This is a cricoid. This is a thyroid. The ligament connecting the thyroid gland to the basically the capsule of the thyroid gland to the cricoid cartilage. This connection, this ligament is called as a suspensory ligament of Berry. Okay, it is basically helping the gland to move up and down during deglutition. Okay, deglutition is swallowing. During swallowing, if you can palpate the gland, okay, you just swallow some saliva and see the gland moves up. This is a very diagnostic importance. Uh, that is understanding. We'll see in pathology. We'll see. Okay. Okay. Thyroid gland has an apex and a base. This is apex. It's but obvious. Apex and base. Base is a bit broad. Okay, I'm covering that much anatomy which are important for the exam point of view only, not any other things, other additional points, other details. I'm skipping them all. Okay, there are a lot of things you can study about thyroid gland, but which are relevant from your point of view. Okay, that is important. So apex is limited by your superior thyroid artery. Your superior thyroid artery is present like this along the apex. Okay, and base obviously inferior thyroid artery. ITA and ST. You know what are the which branches are of which artery? I am not gonna tell them all. Okay. Okay. If this is clear, we'll discuss about the surfaces. Okay. So surfaces, we have a lateral surface, we have a medial surface, we have a posterior lateral surface. Three surfaces. Okay. So we have three surfaces. That is, one is a lateral surface or a superficial surface, you can say. Okay, lateral surface. We'll see how these are oriented. Just pay attention. Then we have a medial surface, lateral surface, medial surface, and posterior lateral surface. Three surfaces are there. I'm drawing a cross section of your transverse section of your neck. Okay, we'll see what are the anterior and posterior. This is the anterior. This is the posterior. This is a transverse section of your neck in this level. Okay, anterior, posterior. So here we have in this part we'll have a muscle which is sternocleidomastoid. We can just erase this half part of the diagram. We'll don't need this part basically. Okay, this is your muscle sternocleidomastoid and another sternocleidomastoid of opposite side. This is your SCM. Okay, then we have the trachea and esophagus as well in this part. Here let's say the trachea. Here is the esophagus. Trachea lies in front of your esophagus. You know that. Okay, then trachea. So here we'll have our thyroid gland. I'm writing TG, not triglyceride, thyroid gland. Okay, and to the thyroid gland, lateral to the thyroid gland, we'll find our superior belly of omohyoid muscle. Here we'll have our superior belly of omohyoid muscle, OH omohyoid. Okay, then again, uh, hmm, okay, then we'll have our sternohyoid muscle just a bit in front of your superior belly. This is your sternohyoid muscle, sternohyoid muscle. Okay, and here another muscle is there. Here I'm changing the colors, otherwise it will cause confusion. This one is a sternothyroid muscle. Okay, done. So now we are ready to write the relations. So lateral surface, what are the relations? All of them. All are your relations: sternohyoid, sternothyroid, superior belly of omohyoid, I'm writing SBOH, just pay attention, and sternocleidomastoid. Could you understand? These are all your lateral relations, right? And what are the medial relations? The medial surface, the relations of the medial surface. Remember, the medial surface, the relations have a rule of two. Have a rule of two. What is the meaning of rule of two? There will be two tubes, two nerves, two muscles which are there in the relations. What I said? TNM. Actually, TNM is a grading system which is used in surgery. Okay, TNM grading is a grading in surgery. So you can just remember this is not related to surgery in any aspect, but you can just use to remember TNM. What is TNM? Two tubes, two nerves, two muscles. What are the two tubes? Esophagus, trachea. Esophagus, trachea. What are the two nerves? Remember, inferior constrict. I'm saying, yeah, external laryngeal nerve and recurrent laryngeal nerve. Easy to remember. ELN, RLN. Two muscles. Inferior constrictor. Inferior constrictor. You can. Okay, you can't appreciate because it's the medial surface, right? We can draw it here. Okay, and cricothyroid. Understood? Inferior constrictor and cricothyroid. These are your relations of your medial surface. And your posterior lateral surface, just see here we have something called as a carotid sheath present in this region. Posterior laterally, this is posterior laterally, right? Attention, this is posterior laterally in this direction. So posterior laterally, in posterior lateral surface, we'll have our carotid sheath. Done? Okay. Yeah. Then we have our borders of thyroid gland, and borders we have. In the borders of thyroid gland, we have an anterior border and a posterior border, right? Anterior and posterior. What are the relations? In the anterior border, we'll have a superior thyroid artery, ST. In the posterior border, we have our anastomosis between superior thyroid artery and inferior thyroid artery, STA and ITA. Understood? Done? So this is the fact about borders. And there are relations of isthmus as well. Okay, this is your isthmus. So isthmus will have relations. Isthmus have two surfaces, two borders. You have to read it repeatedly so as to remember. Okay, it's not that if you read it once or twice, you will remember all this. Okay, two surfaces. Isthmus will have two surfaces. One is your anterior and posterior surface, right? Anterior, posterior. Two borders. What are the borders? Superior, inferior. You can imagine a cuboid now. This is your isthmus. This is your isthmus. Anterior, anterior, posterior. Two borders. Two surfaces, right? Like that, you can remember. Basically, it's a tube type of thing, just a connection. So it's not very prominent like that. What are the relations of your anterior surface? Anterior surface will have these muscles as well. This muscle, sternohyoid and basically sternothyroid. Okay. Posteriorly, tracheal rings, right? Second to fourth tracheal cartilage. I think TC. Okay. Superior, you have superior thyroid artery, and inferior you have something called as a thyroidema artery. Done. So these are your relations. Okay. And now we'll see the arterial supply of your thyroid gland. Arterial supply of thyroid gland is very easy. Then just pay attention like this. This is a thyroid gland. Okay. So basically, if this is a thyroid gland, we'll have an ICA and ECA as well. I'm drawing it very hyper schematically, so don't pay attention. This is your ICA, this is your ECA, okay, and this is your CCA as well. This is your CCA, and this is your subclavian artery, SCA. And from the subclavian artery, remember, there originates a thyrocervical trunk. You all know this. And a branch of thyrocervical trunk will be going here. Branch of thyrocervical trunk will be going here and supplying it from below. This branch is called as the inferior thyroid artery, not internal thoracic artery. Remember, this is the inferior thyroid artery. Okay. And another branch of ECA will come and supply the thyroid gland, and as well as the isthmus as well. This is your STA, superior thyroid artery. Right? And this STA, a branch of STA goes backward, goes behind the thyroid gland, and a branch of ITA also goes behind the thyroid gland. And there is an anastomosing point here. There is an anastomosis between STA and ITA, and this is the relation of your posterior border. Easy? Yes. That's why I didn't explain this anastomosis that time. Okay. And another thing, from the arch of aorta, there originates a thyroidema. This is a thyroidema artery. Okay. This is the relation of your isthmus. Then, if this is clear, yeah. Another thing is that do you know about your parathyroid gland as well? Parathyroid gland is present posteriorly to this thyroid gland like this. Okay. Done. So this is all about your arterial supply. We'll go to the venous drainage of the thyroid gland. Let's talk about the venous drainage. Um, okay, okay, we can see this, right? It will be time consuming drawing the whole diagram. So let me switch to my notes, which I have drawn the diagram. Just a minute. Look at this. This is the whole venous drainage of the thyroid gland. If you can appreciate the diagram. Okay. These are your both lobes of the thyroid gland, the 1 and 2. Understood? And here we'll have our right subclavian and the right brachiocephalic vein, which are like this. The inferior IJV is there. Okay, here is also an IJV. There is a left brachiocephalic vein. Okay, so you know the basic framework. And from this upper part, your superior thyroid vein is draining into internal jugular vein, and your middle thyroid vein is draining into internal jugular vein at this level. And another vein which is important, that is called as the fourth vein of Kochner, not always present, and it drains into the basically the junction part, or you can say the right brachiocephalic vein. Okay, it drains into the right brachiocephalic vein from the lower part of the thyroid gland, and from the left brachiocephalic vein there originates something called as your ITV. Just remember this point, that from the left originates our ITV, not from the right. Okay, and this inferior thyroid vein not originates, basically it drains because it's the vein, so it is taking the blood away from the to the heart. Okay, so basically this ITV is draining into a left brachiocephalic vein, and STV into internal jugular vein, MTV into your same internal jugular vein, and another the fourth vein of Kochner. Understood? And left brachiocephalic vein is always longer from the right brachiocephalic vein. Okay. So that was about the venous drainage. Lymphatic drainage, upper part drains into upper deep cervical lymph node, lower part drains into lower deep cervical lymph node. Okay. And nerve supply, superior cervical, middle cervical, and inferior cervical ganglions. All three ganglions will have the nerve supply to your basically the sympathetic ganglions. So the nerve supply will be vasomotor. Okay, the vasomotor sympathetic ganglions are basically supplying the thyroid gland, and the major one is the middle cervical ganglion. Basically, it's present in that region only, so it's the major one. Okay, and arterial supply we saw now. So this is the basic anatomy. We are done with the anatomy. Let's move on to the physiology of the thyroid gland ASAP. Okay, so let's start the physiology of thyroid gland. Starting with the physiology, we'll discuss the thyroid gland and its hormones. Development is 11th week of gestation. I'm not going to embryology part because it's not very important as far as the thyroid gland is concerned. So Kocher got the Nobel Prize in Medicine in 1909 due to his research in thyroid gland. And regulation is by, you know, the levels of regulation, hypothalamus. The TRH is there. TRH will act on the anterior pituitary. From the anterior pituitary, TSH will be released. That is your TRH is thyroid releasing hormone. TSH is thyroid stimulating hormone. And thyroid stimulating hormone stimulates the thyroid gland, releasing T3 and T4. This is the basic regulation part. And talking about histology you read in anatomy, but here I've covered it in physiology. Let's see that this the transverse section. This is a part of your thyroid gland, and we'll have our thyroid follicles here. Thyroid follicles are lined by your simple cuboidal epithelium. You know this, and we have a colloid inside it. We'll see what are the things with other. This cells are called as the follicular cells. Okay, these are your thyroid follicles, and the cells are called as the follicular cells. And in between them, we have the C cells or parafollicular cells, which are secreting calcitonin. Okay, parafollicular cells secrete the calcitonin. People make a mistake that parathyroid gland secretes calcitonin. This is false. The C cells, parafollicular cells, not parathyroid gland. Okay, parafollicular cells are secreting your calcitonin. And here in the colloid, we have something called the TGB, that is a thyroid binding globulin. Okay, and the connective tissue or your stroma is present here. Done. Blood supply is a superior and inferior thyroid artery. We discussed about all this. Venous drainage, external jugular vein, and innominate vein. We all discussed the innominate vein is basically the fourth vein of Kochner and ITV, MTV, and all that. Okay. Let's start about iodine. Iodine is the raw material in form of thyroid hormones. So source of iodine is, sea fish is the richest source. Okay. Dairy products, egg, this all. Table salt is important. Average daily intake is 500 mg. Daily requirement is 100 to 200 mg. So basically, in Indian population, we are consuming more iodine, which is required. Okay. And normal plasma concentration of iodine is 0.3 mg per dl. 0.3 mg per dl. Okay. So basically, there is a phenomenon which is called as your. This is basically the thing which you have to understand. Okay. So if you're not comfortable with this, should I draw it for you? Okay. I feel so that you have to understand this. So let me draw it. Let's say you have a blood vessel here. This is your blood vessel. This is your blood vessel. And in this blood vessel, we will take one follicular cell. Okay, we'll take one follicular cell. This is a follicular cell, FC, follicular cell. Okay. And in blood, we ate iodine, we took salt, iodine came to blood. This iodine must be trapped inside this follicular cell because iodine is the raw material of synthesis of thyroid hormones. So we're discussing thyroid hormone synthesis. So this iodine must be trapped into the follicular cell. And for this trapping, we need something called as a sodium iodide symporter or iodine pump. So basically here we'll have something called as a NIS. NIS stand for sodium iodide symporter or your iodine pump. So what it will do? It will take this iodine inside the cell in the form of I minus. Okay, and this iodine is said to be trapped, but it is a symporter, so it will require another molecule to be transported. What will be transported? Sodium, Na plus. Okay, and this iodine which is trapped is basically released into here. If it is a follicular cell, you'll have your colloid. You'll have your colloid in this part, right? This is one follicular cell. Okay, if you have not understood this, just let me draw it. These are your follicular cells. This is your colloid. So basically, we are looking at this region. We are looking at this region. Okay. Okay. If this trapped iodine comes here, and there is another pump. There is another pump which is called as your iodine chloride anion symporter. Iodide chloride anion symporter. There is a special name for this which is called the pendrin. Okay. Pendrin. Very special. I'll tell you. I minus Cl minus symporter. So by this I minus Cl minus symporter, this iodine will move out here I minus, and this chloride will move out also. Okay, because this importer, same direction, and move out to the colloid. They will move out to the colloid. And this pendrin is a very important thing, because if there is a congenital defect, if there is no pendrin, if there is a congenital defect in pendrin, then hypothyroidism will occur and hearing loss will occur. Very unrelated symptoms. This absence of pendrin will cause hypothyroidism plus hearing loss. Okay, this both is called as a pendred syndrome. This is important. Pendred syndrome is an important question for the PG point of view. Okay, and this pendrin, remember, it's present in many regions. Basically, hearing loss is occurring. So, we will that it is present in ear. Okay, so it is present in your ear. It is present in your salivary glands. Okay, the salivary glands will have pendrin. So basically, all the pendrin is absent. There's a congenital malfunction, then many things will occur. But this hypothyroidism and hearing loss is basically well established in case of pendred syndrome. Okay, your mammary gland, your ciliary body, all this have. Okay, mammary gland, your ciliary body, this all things will have your pendrin. Okay, this is a pendrin syndrome. Okay, let's come back. So in colloid, this I minus came. Okay, let's now draw the colloid again. This is a colloid. So what is happening in colloid? Pay attention. I minus came. I minus will be oxidized. It's in -1 state. It will be oxidized. So there will be increase in oxidation state, that is +0. It will oxidize to I2. I2 will have 0 oxidation state. So it is basically oxidized first. Oxidized. Oxidized with the help of which enzyme? Thyroid peroxidase. Thyroid peroxidase enzyme. Understood? Then this oxidized iodine, this I2, which is now not iodide, which is iodine, is combined with the a molecule is called the tyrosine, and this combination will produce what is called the MIT, monoiodide thyrone. Okay, MIT, and this MIT, if it combines with another MIT, will form a DIT, that is diiodothyronine. This MIT, if it combines with another DIT, will form a triiodothyronine, and this triiodothyronine is called T3. If this DIT and DIT combine, what will happen? Basic maths. T4, tetraiodothyronine. Okay, this is your T3, this is your T4, and this T4 is called your thyroxine. This T3 and T4 are then sent to your follicular cell again. This is sent to your follicular cell again, which is stored. Okay, it is stored. Very important. Thyroid hormone, thyroid gland is the only gland which stores its released product. Okay, so only gland, and this is stored for 2 to 3 months even. Okay, or 3 to 4 months. Some books write 2 to 3 months, and these are released into blood when required. So, could you understand what is happening? I discussed to you the whole mechanism of how the thyroid hormone is being made and synthesized, and how it's stored, what are the things, what is pendrin, what is pendred syndrome, and all. Okay. So now let's move ahead. This is all I talked. This is the whole mechanism. Basically, we don't need this because this is at the molecular level. Yeah, this is important. Effects of thyroid gland. Effects of thyroid hormone. Basically, thyroid hormone increases the whole metabolism of your body. Okay, the metabolism is increased. Basal metabolic rate is increased up to 60 to 100%. Yeah, 60 to 100% above normal. It will increase utilization of food. It will increase the rate of protein synthesis. It is synthesizing and catabolism as well. Increase activity of all endocrine glands. Increase neuronal functioning. Increase activity of mitochondria. Increase in rate of ATP synthesis. Increase cellular oxidation. Increases sodium potassium pump action. So all the things which are related with the metabolism is increased by this thyroid hormone. Okay. What is the effect on CVS? It will increase the formation of metabolic end products, increase the cardiac output, increase cardiac heart rate, increase contraction, increase blood volume, increase pulse pressure. Yeah, it will increase the systolic blood pressure and decrease the diastolic blood pressure, because diastolic blood pressure is determined by your peripheral resistance. If you have seen my blood that lecture on your regulation of blood pressure, I have told this. Okay, so decreased peripheral resistance will be caused by thyroid hormone, which will decrease the diastolic BP. Okay. In respiratory system, increase in depth of respiration. Metabolism is increasing, so we need respiration, we need oxygen. Increase utilization of O2, increase formation of CO2. More oxygen utilization, more CO2 production. Okay, these are things. GI tract, increase appetite, increase rate of secretion of digestive juices, increase GI motility. So, increased GI motility means if there is an excess of thyroid hormone. Okay, if there is an excess of thyroid, that will increase GIT motility. So, hyperthyroidism will have a manifestation, that is diarrhea. Diarrhea. Diarrhea will have increased motility. And if there is hypothyroidism, there will be decrease in your GI motility. So it will cause constipation. So hyperthyroidism will have diarrhea and hypothyroidism will have constipation. Okay. CNS development. Basically, there is a development of CNS. Infancy and early childhood, proliferation of axons, myelination will increase. Okay, hyperthyroidism will cause extreme nervousness and psychoneurotic tendencies, anxiety. Anxiety is the main problem in your hyperthyroidism as well. Okay, and basically if thyroid hormones increasing all the things, then the body will have tendency to become more stimulated. Okay, anxiety and irritability will increase obviously in hyperthyroidism. Muscles, growth of muscles, increase muscle vigor. Okay, and yeah, excess secretion of thyroid weakens the muscle. Okay, if there is more thyroid, like hyperthyroidism, we have something called hyperthyroid crisis. In that, the thyroid hormone will increase the protein catabolism, right? So if there is increased protein catabolism, the muscle will be getting digested. Like the muscle proteins will now get coagulated and digested over. Okay, so there will be increase in muscle weakness if there is extreme hyperthyroidism. Okay, hypothyroidism, sluggishness in muscle. Okay, and hyperthyroidism, hyper will have tremors. Okay, due to increase in neuronal activation. More neuronal activation, more CVS is active, and there will be more hyperthyroidism. Sleep, insomnia. One effect, insomnia. Okay, there's more thyroid. Reproduction, it is important hormone for your gamete, that maturation of gametes, spermatogenesis. Promotes spermatogenesis. Okay, and if there is hypothyroidism, there is a complete loss of libido, that is a sexual power. Okay, there's a complete loss of your libido. And hyperthyroidism will cause oligomenorrhea, that is reduced bleeding. And action of thyroid hormone cannot be pinpointed to a specific function. Yes, this is important because you can't say on which manifestation the thyroid gland will show if there is increase or decrease. So you can pinpoint the action to that particular thing. Okay, sometimes it will cause irregularity, sometimes it will promote the gametal that maturation, sometimes it will be beneficial, sometimes it will be detrimental. You can't say. Endocrine glands, increase in rate of secretion of endocrine glands. Body weight, hyperthyroidism will cause loss of body weight. Okay, and hypothyroidism will cause increase in body weight. So a hypothyroid patient will be more fat, and hyperthyroid patient will be less fat. Okay, growth will cause skeletal growth in children and help in eruption and development of teeth. So hypothyroidism child, a child with hypothyroidism will show this type of dental irregularities and increase in brittleness of bones. Okay, kidney, it will increase all the metabolism, increase RBF, increase GFR and all. Okay, so in blood, T4 is more and T3 is less. T4 is the main, the thyroid hormone, thyroxine. Okay, and in blood it is 75% in bound form, that is bound to TBG, thyroid binding globulin. 20% bound to pre-albumin or transerythrin, and 5% bound to albumin. Okay, these are your basic levels. And yeah, in blood, 8 mg per deciliter is the concentration of T4. 0.15 mg per deciliter is the plasma level of T3. Okay, there is something called as a Wolff-Chaikoff effect and a Jod-Basedow effect. Okay, so what is Wolff-Chaikoff effect? What is Jod-Basedow effect? Let me tell you that if there is excess of intake of iodine, if there is excess iodine, then what will occur? There will be decreased synthesis of T3 and T4. Okay, iodine induced hypothyroidism is called the Wolff-Chaikoff effect. So if there is excess iodine, there is decreased T3 and T4. Okay, because there an enzyme act which is called the D1 diiodinase. Diiodinase will enzyme will act and will break down this T4 active T4 to T3. This T4 to active T3. Okay. Basically, by blocking the organification step, excess iodine will have a feedback effect to block the organification step and cause a hypothyroidism. Okay, and Jod-Basedow effect, what will occur? If there's excess iodine, there can be a tendency of increase in synthesis of T3 and T4. Will cause your hyperthyroidism. So basically, these are antagonistic effects. Okay, these effects are not pinpointed to what will occur. In Wolff-Chaikoff, excess iodine decrease in T3 T4 due to feedback effect. In Jod-Basedow, excess iodine increase in T3 and T4. So it's a tendency that you will get confused, but it's what it is. Okay. These are your actions. We discussed the actions in great details, so I'm not going. Yeah, another thing, increase in rate of conversion of carotene to vitamin A. Okay, it will cause a yellowish orange tint of skin. So in hypothyroidism, there is increase in conversion of decrease in conversion of carotene to vitamin A. Thyroid hormone promotes the conversion of carotene to vitamin A. In hypothyroidism, there is increase in carotene, so there will be yellowish orange discoloration. Okay, tint. Effect of GIT we saw. Effect of adipose tissue. Thyroid hormone increase rate of lipolysis, that is breakdown of fat. Okay, so hyperthyroid will have thin and hypothyroid will be present. Okay, to revise this all. Another thing is that important that thyroid hormone is thermogenic hormone. Thermogenic hormone, that is a heat producing hormone. Okay, because there is increase in metabolism, so obviously any biochemical reaction will have an production of heat, any metabolic reaction. Let's talk about the disorders. Okay, in disorders we have the hyperthyroidism first. Most important, the Graves disease, which is also called the Perry's disease, Basedow's disease. Okay, thyrotoxicosis is just a variant of it. Okay, or your it's a primary disorder. Okay, it's a primary disorder. Problem is in the thyroid gland itself. Okay, it's the autoimmune disorder. TSH stimulating antibodies are present, which will stimulate your TSH and will increase the levels of T3 and T4 chronically. Okay, what will be the effect? You can see there is a condition called as your exophthalmos or your thyroid ophthalmopathy. Okay, it's also called as a proctosis. Three in terms: exophthalmos, proctosis, or thyroid ophthalmopathy. These are your conditions. So it will affect the muscles around the eyeball. It will push the eyeball, causing edema. There is edema of retrotubular tissues which are present behind the eyeball. Okay, it will push the eyeball outside, and there will be infiltration of fat. Okay, and degeneration of extraocular muscles, which will bring out your eye like this. Okay, you must have seen the meme Momo. Okay, the scary creature like that. Other causes, many causes of hyperthyroidism are there, like solitary toxic adenoma, multinodular cancer, TS secreting pituitary tumor, iatrogenic, that is drug induced, and ectopic thyroid issues. Okay. Thyroid storm is also called the thyroid crisis, in which large amount of thyroid hormones are secreted in the less time. Okay, there's a burst of thyroid hormone synthesis, and it also occurs in hyperthyroid patients. Let's talk about hypothyroidism now. In hypothyroidism, we'll have a congenital hypothyroidism called as a cretinism. Cretinism. So in this cretinism, we'll have a idiotic look. Idiotic means idiot. Idiot, you know? Okay. Idiotic look or idiotic look. So there will be a thick parted lips, protruding tongue, broad nose, and pot belly. You can just search a image of cretinism you get and just see the patient. Okay. Occurs in child, dwarf stature, plus all the features of hypothyroidism. Now you understood the functions, you can very well establish the general features of hypothyroidism, and mental retardation will be present in this. This is important, in which mental retardation, in which it is absent or present. So this mental retardation itself is a very important indicator, because you can differentiate between a pituitary dwarf and a cretin dwarf. Okay, in cretin dwarf there will be mental retardation. In pituitary dwarf, okay, due to less secretion of growth hormone, there will be no mental retardation. Yes. Okay. Let's talk about myxedema or Gulls disease or myxedema, in which edema will occur due to accumulation of the substances of your ECM, extracellular matrix, that is chondroitin sulfate and hyaluronic acid. So this all will accumulate. These are your gel-like substances. So if there is a edema, okay, if there is an edema, to push the skin, if we push the swollen organ, then it will come back. It will rebound back. This is called the non-pitting edema. Okay. Causes of hypothyroidism, it may be maternal iodine deficiency, fetal thyroid dysgenesis, inborn errors, okay, antithyroid antibody, and hypothyroidism. Causes of hypothyroidism in adults, diseases of thyroid, pituitary failure, and hypothalamic failure. Now, let's talk about goiter. Goiter is the enlargement of thyroid gland, doesn't denote functional status of the gland, may occur in any state. Okay, it may be it may be the reports are like normal, but you have goiter. The reports are abnormal and you have goiter. You have hypothyroidism with goiter, or you may have hyperthyroidism with goiter, or it may occur in euthyroid state, that is normal functioning thyroid. Goitrogens are the substances that interfere with thyroid hormone production and increase the risk of your goiter. Thiocyanate, nitrates, perchlorates, thiouracil, all this. Iodine deficiency goiter, if there is iodine less than 10 mg per iodine per day, okay, less than 10 mg iodine per day consumption, there will be iodine deficiency goiter. Okay. And what is the treatment? Food fortification. That is, you must give the iodine, okay, in your diet. That's that. And what I told, pituitary dwarf versus cretin dwarf, you can take a screenshot of this. Very important question, which are asked in your prof exams. Done? Okay. So that's what about the physiology of thyroid. Let's move on to the biochemical aspect of thyroid gland. Okay. So welcome to biochemistry of thyroid. Basically, there's all things we know from anatomy. What are the secretions we know from physiology? What are the functions? Increase BMR, protein synthesis, increase in blood glucose, maturation, development, utilization of lipids. Utilization of lipids means lipolysis. Yeah. Thyroid molecules get attached to tyrosine, that is residue of thyroglobulin. We know this. Yes, tyrosine, I told, forming MIT and then DIT. These are all things we know. No need to discuss. TRH, if, yeah, there's a concept of primary, secondary, and tertiary disorder, which I had left in the physiology part. Let me discuss this here. If there is a disorder of your T3 and T4, if there is a disorder of T3 and T4 at this level, so it is called a primary disorder. If disorder is at higher level, that is at anterior pituitary level, if there is a tumor, or if there is an obstruction, or by some means your TSH is not being released, so that disorder is called a secondary disorder. And if there is a disorder at tertiary level, that is upper level, even up, like hypothalamus, okay, there may be hypothalamic syndromes and all, which will cause your tertiary disorder. So these are primary, secondary, and tertiary disorders with respect to thyroid gland. Hypothyroidism we know, hypothyroidism decrease T3 T4, increase TSH, obviously. T3 T4 will be decreased, and because these are not producing, TSH will increase uncontrollably, right? And in hyper, increase T3 T4 and decrease TSH. Easy. What are the cases we saw? Iodine deficiency, goiter, Hashimoto's thyroiditis, secondary hypothyroidism, tertiary hypothyroidism, okay, all this. And hyperthyroidism, Graves' disease, nodular goiter, and goiter. Okay, I mean, it's multinodular if you don't. Normal T3 and T4, but TSH level affected. T3 and T4 are normal and TSH is abnormal. Unique case called as subclinical hypothyroidism. Very important, just remember this. Graves' disease, symptoms, there is an easy technique to remember: goiter. It's not related with goiter, but the technique is, the mnemonic is goiter. Okay. Gland enlargement will occur, edema, irritability, tremors, restlessness, excitability, and heat tolerance. Okay. We saw this statement. What are the percentages? 75, 20, and 5. You know this from physiology. TSH. TSH is a sensitive and specific test for assessing thyroid function. So in biochemistry, we are focusing on assessment of thyroid function, and TSH is a sensitive and specific test for your thyroid functioning. 0.5 to 50 mu IU, okay, international unit per liter is the normal TSH levels. Free T4 level is normal is 0.7 to 1.8 milligram per deciliter. Okay, so we are now seeing the approach to the patient. A patient comes with hypothyroidism. Okay, a patient comes with hypothyroidism. Ask the patient first for TSH and free T4. Ask the patient first TSH and free T4, FT4. Okay, these two tests are written in prescriptions as well. If there is increased TSH and decreased T4, TSH is increased and T4 is decreased, that means primary, right? Because this T4 is what it is affected, primary hypothyroidism. If there is primary hypothyroidism, you can ask the patient to do a TPO antibody. Okay, TPO-AB, TPO-AB. If there is, TPO-AB is done for autoimmune origin. If TPO-AB is positive, then Hashimoto is there. If TPO-AB is negative, it's normal gout. Diagnosed? Yes. So what it will, patient comes, you will see, observe the features of the patient. Okay, you can very well correlate if it is hypothyroidism or hyperthyroidism. So you feel like he has hypothyroidism. So first what you will do, you will ask for TSH and FT4. Yes, if TSH is increased and FT4 is decreased, means primary. Primary means you will ask for anti-TPO. Anti-TPO, if it is positive, Hashimoto's. If it is negative, then iron deficiency goiter. If there is increased TSH and normal FT4, if FT4 is normal, that means T4 and T3 are normal, but TSH is abnormal. What we told? Subclinical, with seen earlier. Okay. If there is decreased TSH and decreased T4, both are decreased. Okay, then you have to prescribe TSH stimulation test. TSH stimulation test to assess the function of TSH as well. And if TSH is normal, then you can tell that we have the pituitary causes of hypothyroidism. Pituitary causes. And if there is delayed increase in TSH is being delayed in increasing, then we can say that you can rule out pituitary and say that we have hypothyroidism, the hypothalamic causes of that disease. Okay. In hyperthyroidism, TSH and FT4, same prescription. Question comes to hyperthyroidism, you first ask for TSH and FT4. If there is decreased TSH and increased FT4, it is primary hyperthyroidism. If there is decreased TSH and normal FT4, prescribe FT3. FT3 is not prescribed in normal cases. Only if there is a decreased TSH and normal FT4, then prescribe FT3. Okay. And if there is increased TSH and increased FT4, both are increased, then there is a resistance to thyroid hormones. Okay. All are increasing means there is some resistance to thyroid synthesis. There is some pituitary causes. You can rule out pituitary causes in this level. You have to assess all the functions now. If there is decreased TSH and normal FT4, FT3 is prescribed. If FT3 is normal, that what it means? Means FT3 is normal, FT4 is normal, TSH is abnormal, subclinical. If FT3 is raised, then you know that it is T3 thyrotoxicosis. That is, FT4 is normal, TSH is decreased. Okay, that is no problem. And but FT3 is being increased. That is, problem is in FT3. So FT3 thyrotoxicosis. Okay, we'll read in medicine what to give in, what is the management of all this. We'll read in medicine. And if this decreased TSH and increase FT4, okay, then do anti-TRH antibody. Okay, if anti-TRH is positive, autoimmune Graves disease. If anti-TRH is negative, then you have to prescribe radioiodine uptake studies. Radioiodine uptake studies will give you a whole outline if it is due to toxic nodular or it is multinodular. Okay, so it is a bit complicated procedure. You have to set the algorithm in your mind what to prescribe and when. Okay, you can't prescribe all these tests to a patient. It will be very costly for him to test all this. Okay, have to be economical with the patient. Other tests for assessing thyroid function: USG, CT scan, FNAC. Okay, all these are done. And calcitonin level is a marker for medullary carcinoma of thyroid. Medullary carcinoma of thyroid we'll see in pathology. So calcitonin level is a marker of that. Okay. And other tests: thyroid binding globulin test, TBG, and radioiodine uptake studies. Okay. These are your biochemical aspects of thyroid gland. This all. You have to just take the screenshot of this first: hyperthyroidism, and then and this the approach to hypothyroidism. This both things you have to register in your mind, read repeatedly, and by that you will master the thyroid gland. Now done. Okay, so now we'll start about the pathology of thyroid gland. Very interesting. We'll start. Welcome. So here we are in thyroid pathology now, and in thyroid pathology we'll deal about all these things which are important for your pathological point of view of thyroid gland, and after pathology we'll wind up this lecture. Okay, so bear more 10-20 minutes with me, then we are done with all the aspects of thyroid gland. Okay, basic histology of thyroid. Here very important thing: if the follicle is inactive, then the colloid is thyroglobulin present. Okay, but if the thyroid follicle is active, the active thyroid follicle, 10 to 15% population of thyroid follicle is active, so it will have a scattered margin. It will have a scalloped margin, not scattered. Scalloped margin, that is 8 margin. The margins are like consumed somewhere, patched. Okay, teeth like. You can see here a scalloped margin. This is a active follicle, and inactive follicle just uniform margin. Understood? Thyroid function tests we saw: T3, T4, TSH. Hypothyroidism we saw: T3, T4 decrease, TSH increase, means pituitary is normal. Primary. If T3, T4 decrease, TSH decrease, means pituitary problem is there. It is secondary. If there is hyperthyroid, T3, T4 is increased, TSH is decreased, means there is no primary hyperthyroidism. If T3, T4 is increased and TSH is also increased, means there is secondary. So you can remember like this: in secondary problems, there is both increase or both decrease. But in primary problems, the increase and decrease are in one parameter. Okay. After this, let's see. We can do FNAC also, fine needle aspiration cytoscopy, and an adequate FNAC will have 6 follicles of minimum 10 epithelial cells each. Okay. So this is an FNAC finding of the thyroid gland. And basically, thyroid FNAC is done by inserting a very fine needle inside this and all. These things we saw just a minute. These things we discussed, right? This diagram was there in physiology. I just copy pasted the diagram because I felt like it's important. Okay, yeah, let's talk about this now. We saw that in temperature, cold intolerance is found in hypothyroidism, and heat intolerance in hyperthyroidism. And menstrual cycle, heavy menstrual flow will occur in hypothyroidism and scanty in hyperthyroidism. But we can't pinpoint any action as what we learned. Okay. Graves disease, we discussed about some things about Graves disease, and some other things we'll discuss in pathology. That is hyperthyroidism, obviously most common in women, that is middle-aged women. Okay, and autoimmune disorders. Just remember that every autoimmune disorder, okay, it is very common in women, and that too in middle-aged. So this is a general feature. And triad is of Graves disease is there. Okay, I left this triad. This is a diagnostic criteria for diagnosing or hypothyroidism. That is, hyperthyroidism will have diffuse enlargement of gland, infiltrating ophthalmopathy, that is thyroid ophthalmopathy or proptosis, plus exophthalmos, and infiltrating dermopathy, that is pretrivial myxedema. Okay. Then we have the modern diagnostic criteria. So hyperthyroidism plus serological evidence of autoantibodies. So this is the modern diagnostic criteria, because in this previous diagnostic criteria there was no evidence of your autoantibodies. But if you find the autoantibodies in serology, then it is a confirmatory finding that you have the Graves' disease. Okay. Pathogenesis, we know antibodies against TSS receptors, and it will form the thyroid stimulating immunoglobulins, so stimulate the thyroid gland repeatedly, causing increase in T3 and T4. And this T3 and T4 are increased for chronically, I told, that is a long acting thyroid stimulators, LATS. LATS is the name of the antibody, long acting thyroid stimulator antibodies. And this infiltration, why there is an infiltration of this ocular muscles and degeneration of these ocular muscles? Due to more activation of CD4 T cells. The CD4 T cells are activated due to this antibodies. Okay. And this will produce an activated macrophages. The macrophages, when activated, just a minute. Okay, so basically some problem occurred with my camera, and I can't be in front of you. No problem, we'll complete the thyroid pathology which is remaining by this. So due to more activation of CD4 T cells, it will produce activated macrophages which will secrete substances like interleukins. This interleukins will attract the fibroblasts, okay, and which will increase your extracellular matrix, GAG and collagen, and this increased extracellular matrix will cause ophthalmopathy or dermopathy, as we saw earlier. So there will be matrix components, there will be cellular infiltration, inflammation associated edema. So this is your dermopathy and your ophthalmopathy, you can see here. Okay. And gross, it will have diffuse enlargement, not nodular, diffuse enlargement. Okay. Microscopy will have increased amount of active follicles. Increased amount of active follicles, there will be more scalloped margin and columnar epithelium. Active follicle, we know that it has columnar epithelium. But okay. And plus might have hyperplasia, because due to repeated stimulation the gland may be hyperplastic at some points. Let's talk about Hashimoto's thyroidism. So it is a hypothyroid condition, most common hypothyroidism in non-iodine deficient areas, that is plain areas. Iodine deficient areas are basically hilly areas, so goiter is called as an endemic goiter because it is endemic to your hilly areas and occurs in middle-aged women, more common because autoimmune disorder simply. Pathogenesis is type 4 hypersensitive reaction. T cells, the T cells will be recognized for T cell will recognize the thyroid gland foreign, and this foreign thyroid gland will cause stimulation of CD4 and CD8 as well. The CD8 T cells, okay, will destroy the thyroid epithelium, and CD4 will form activated macrophages with increased lymphocyte. This lymphocyte will again destroy thyroid epithelium. Okay. So this destruction of thyroid epithelium, if this epithelium is destroyed, it will cause fragments like this. This is called the neoantigen. These fragments are called as a neoantigen formation. This neoantigen will again stimulate your B cells. This B cell stimulate plasma cells, produce autoantibodies, and most of the autoantibodies are produced against the thyroid peroxidase, the main enzyme for organification and oxidation. Okay. And clinically, what are the symptoms? Initially, that will start of destruction, then the stored T3, T4 will be released. There will be transient hyperthyroidism as well. Okay, there will be transient hyperthyroidism. It is hypothyroid condition, but in Hashimoto's, just remember there will be a period of transient hyperthyroidism as well. So you may get confused. So be careful with dealing with Hashimoto's cases. Diagnosis will be FNEC plus serology. Okay. And in serology, we'll do anti-TPO. We saw this earlier in biochemistry to differentiate it from lymphocytic thyroiditis or other autoimmune disorders. And then, okay, this lymphocyte will be present in your FNAC. It will the thyroid follicle will fight back against the lymphoid follicle. So more ATP will be needed. If this more ATP is needed, the increase in mitochondria. Okay, and increased mitochondria means there will be oncocytes present. So we will see the oncocytes in the Hashimoto thyroiditis FNAC finding. Okay, so you will see your oncocytes. These pink ones are your oncocytes. Okay,
And this oncocytic metaplasia, that is metaplasia of oncocytes, the oncocytes will be seen now. This is known as a Hurthal cells. So Hurthal cells is basically an oncocytic metaplasia. Okay, these are your pink cells. Okay, are your oncocytes. Complications, Hashimoto may lead to papillary thyroid carcinoma or follicular thyroid carcinoma. Okay, PTC or FTC. And increased lymphocytes, if it is occurring chronically, that will lead to lymphoma, increased risk of lymphoma, and will cause something called the marginal zone lymphoma. We haven't discussed, but you must have read about this in your classes of hematology, okay, or maltomas. Let's move on to thyroid neoplasms. Papillary thyroid carcinoma, follicular thyroid carcinoma, medullary thyroid carcinoma, and anaplastic thyroid carcinoma. Okay, four major classes of thyroid neoplasm. Etiology is same: radiation, iodine deficiency, or mutations, anyone can occur. Let's talk about papillary thyroid carcinoma, which is the most common thyroid carcinoma. Okay, mutation, the translocation PTC1 and RET gene. Okay, or BRAF B600E mutation. This B600 valine to glutamate mutation will occur, B2E, and 600 means 600 position. The mutation of valine to glutamine at 600 position of BRAF gene. Okay, the most common type of mutation, and the targeted therapy may be used to do this, like vemurafenib. Okay, clinical features, it is just a thyroid swelling. Men with thyroid swelling must be tested. Okay, this if there's a visible thyroid swelling, it must be tested. It may be goiter or it may be carcinoma. Okay, generally irregular swelling will occur here. Diagnosis will be again FNAC, this is ultrasound guided US ultrasonography guided FNAC. Okay, because it is not blind, you know about which parts you are taking the tissue from or which thing you are testing. Okay, and FNAC, what will be the findings of FNAC? There will be intranuclear pseudo inclusions present. There will be intranuclear pseudo inclusions present like this. Okay, you can see within the cell there is a inclusion. Okay, this is pseudo inclusion, and papillary fragments will be seen, and calcification may be seen too. Calcification. If you do the biopsy, okay, and then we'll see some characteristic orphan Annie eye nuclei. Orphan Annie, you know, it's a cartoon like this. This is a cartoon Orphan Annie. Okay, and the eyes of Orphan Annie are hollow, just blank. Okay, so this is the clearance of nuclei. The nuclei is cleared off. Okay, clear nuclei, and looks like Orphan Annie eye nuclei. This is a characteristic finding in biopsy of PTC. And coffee bean nuclei will also be present. If I can show you, just let me find a coffee bean nuclei. Maybe it's not present here. Okay, here you can see something like that. A coffee bean like shape is there, but proper coffee bean is not seen here. Okay, papillae and psammoma bodies will be present. Psammoma bodies, you know, okay, they're found in a PTC. Let's talk about follicular neoplasm, that is follicular adenoma and follicular carcinoma. Mutations will be RAS mutation. RAS mutation, you know, is poor prognosis. In 20 to 40% in follicular adenoma, 30 to 60% mutations in follicular carcinoma. Okay, and translocation 2, 3 is there. PAX, PPARG, okay, seen in this much of percentage. PTEN loss, or it may be P13K gene mutation. It may be any one of them. And clinically, there will be solitary nodule. Remember, that is a solitary thyroid nodule. If there is a solitary thyroid nodule, you do USG guided FNAC, and in microscopy you will see the repeated microfollicles, which are diagnostic of follicular neoplasm. Okay, and remember, FNAC cannot diagnose follicular carcinoma. Okay, and treatment is surgical removal. And post surgery you can differentiate, very funny point, but post surgery, after surgery, you can differentiate between follicular adenoma and carcinoma, because in adenoma there will be no invasion and microfollicles will be present. In carcinoma there will be invasion, either capsular or vascular invasion present. You can see here there is a capsular invasion. This is a capsular invasion. Okay, so if there is invasion, that is a follicular carcinoma of thyroid. If the capsule is intact, no invasion, that is you have your follicular adenoma. Understood? Let's talk about third, medullary carcinoma of thyroid, arises from parafollicular C cells. So remember one point we read in biochemistry, that is calcitonin is a marker. Okay, clinical features: thyroid mass is there, hypocalcemia. Okay, or VIP, patient may present with diarrhea. Mutation is RET mutation, 20% syndromic, 80% sporadic cases, or MEN2A, MEN2B mutation may be there. In gross, there will be uniform swelling most of the times, okay, and solitary nodule may be seen. If you see the HP, then there will be salt and pepper chromatin. Your hematoxylin eosin will have salt and pepper chromatin, that is your heterochromatin is dense and inactive. But if I talk about euchromatin plus heterochromatin, euchromatin is light stained, heterochromatin is dark stained, so you will see a dotted type of structure. Okay, so basically in every neuroendocrine tumor you will have a salt and pepper chromatin. This is a salt and pepper chromatin. Okay, and amyloid deposits may be present. Immunohistochemistry, I told, calcitonin will be present. Okay, also the synaptophysin and chromogranin will be positive. Understood? Microscopy, just look, this is a amyloid present and this is a salt and pepper chromatin. Just if I can zoom, look at this, the salt and pepper chromatin. Fourth one, anaplastic thyroid cancer, that's the last one. Fast growing stridor will be seen due to compression of trachea. Okay, the stridor will be fast growing and trachea will be compressed and will be breathing difficulties, and the stridor will be there. P53 loss, you know, P53 loss means the guardian angel is lost, that is very poor prognosis. And there will be anaplastic plus necrosis, and diagnosis is very poor prognosis. Patient is difficult to save. So by that we complete our all of the things that are there in the thyroid gland. I couldn't switch on my camera in the last few minutes because there's a problem with my camera. Okay, no problem. I hope you understood all the facts. If you have any doubts, you can reach to me at Instagram. At this, okay, this is my Insta ID, and you can ask any doubts. Okay, so that's all in today's lecture. Thank you guys. I hope you liked the lecture. Bye bye.